So we're going to get started with our first presenter today. We have Katie Dixon-Gordon, who received her undergraduate training from the University of Washington, where she worked as a research intern and staff member for Marsha Linehan. And Dr. Dixon-Gordon received her doctoral training from Simon Fraser University, working with Alex Chapman, and completed her internship and postdoctoral fellowship at the University of Mississippi Medical Center. Dr. Dixon-Gordon has served as an investigator on several grant-funded studies of dialectical behavioral therapy, BPD, and self-injury, and has published over 100 theoretical and empirical articles on emotion regulation, BPD, and DBT. She is currently an associate professor at the University of Massachusetts Amherst, where she teaches, conducts research, and supervises the DBT program. And she will be talking on debunking myths about BPD today. Welcome.
Thanks so much. It is my honor to be invited. Thank you all for being here. So I'll share my screen, and I obviously do not know everybody here or the structure for today, but I'll just say, because I have truncated this quite a bit, I'm very happy to answer questions, pause, and cater this in a way that would be most useful for people. So I don't know how you would prefer, Bailey, how do you want that to go? Do you want people to put it in the chat, or what would you like?
Yeah, if people can send the questions in the chat and then we can address them at the end. Would you prefer it sent to you or to myself?
Maybe you, because I might miss it with the multiple screens. Okay.
Of course.
Thank you.
So I will do that and announce it at the end.
Wonderful. All right. So I'll share some slides, and you should be able to see them now. So I will say, I think that a lot of the reason I got into this work was because it just seemed like there was so much mystery and misunderstanding related to this diagnosis. And so I remember kind of being a little bit confused by that when I first encountered it, and just wondering, like, what is all this about? And like, why? And I stumbled onto Marsha Linehan's research, and I was at the time a student at the University of Washington. And I had kind of walked around with this confusion about, why is there this kind of shroud of mystery and misunderstanding or related to this diagnosis? And that's what really prompted me to do this work, was that I just really felt like this was a cluster of symptoms and a diagnosis that often got short shrift, that people often misunderstood. And so I was really excited by the idea of DBT, because it was, now there's many treatments for BPD, but at the time it was still kind of coming out of this idea of being untreatable. And so I was really excited to be able to learn more about how this was actually a cluster of problems that could be treated. I'll just mention some disclosures. I don't think I'm talking about I'm not going to talk about off-label drug use, and these are just some potential conflicts to declare. I don't think I need to tell this group necessarily why I think these are important topics, but I'll just say that I think that the source of a lot of the misunderstanding related to BPD is because it's scary for therapists to worry about their clients. That's the way I kind of think about it. And so conditions that bring up a lot of worry for clients, I think, sometimes might bring up the possibility of having a lot of myths and misunderstandings. And in particular, I'll just kind of mention that these are the kinds of things that really freak therapists out, is when their clients are engaging in harm to themselves, When their clients are maybe expressing a lot of distress and not a lot of positive emotions in the room. It can be, therapists are just people too. And so I think that is maybe one of the reasons why we see in medical providers some pervasive and persistent misunderstandings related to this diagnosis. Hang on, I'm going to just reshare my screen because I'm noticing a little bug in my system here. Okay, there we go. I think that I fixed it. Sorry, y'all. All right. So, so as I said, this is a little bit of a truncated, highlights. So I'll just briefly walk through. If you all can see my screen again, I'll talk about briefly what is BPD. Well, actually, and some myths related to each of these topics. So the first myth is often that BPD is not real. It's often referred to as a wastebasket diagnosis. And I'm not going to go in detail around the specific criteria, except to say that there is a great deal of heterogeneity. That means that there's a lot of variability from person to person. You could have two people who both meet criteria for this disorder, and they could look very, very different. And so I suspect, again, that that's part of the underpinnings of some of this confusion around what this is. That said, we're consistently seeing over and over again that however we assess for BPD, that it does seem to kind of hang together. And even when we think about, is this better considered dimensionally? It does seem like at minimum, these are clusters of symptoms that people are in fact struggling with, regardless of what we call it. And in fact, this addresses our second myth of whether or not it's rare. A lot of people think that, like, oh, I don't know anybody with BPD. Probably you do. Therapists who think that they don't treat BPD, probably they do. And so I think that brings us to this idea that actually BPD is a lot more common than I think we often think. The population rates are relatively low, 2 to 6%. However, most populations that I encounter in my daily life, college students, people walking into a clinic, we see much higher rates. So college students, we see rates of about 10%. Same thing in emergency departments. People who are in the primary care business, over 18% of primary care patients are meeting criteria for BPD likely. Nearly a third of visitors to psychiatric inpatient units and pain clinics. And so when we start thinking about specific settings, actually the likelihood that we're encountering people with BPD starts to get a lot higher. And I think that this is really important to know for people who are providers, that even if you think you aren't treating BPD, you might be, and we should all be screening. And I think it's especially important for patients, because I think part of the diagnosis of BPD goes along with this feeling of kind of alienation and isolation, which I think communities like the BPD Society of BC are really important antidotes to. This third myth is that BPD only affects white women. And I don't really think anybody would say that this is true. But I still think that people have in the back of their head a lot of the time, oh, this couldn't affect me or shouldn't affect me because X, Y, or Z. And I think in part the media presentations have somewhat perpetuated this idea, but we know that actually BPD is popping up with comparable rates around the world, that we see similar rates across countries. There's actually similar rates among males and females in some, but not all studies. And similar rates across different racial and ethnic groups, although we see some evidence of some elevated rates in some US Hispanic samples. I think this fourth myth is, again, one of those myths that I think is a little bit insidious. I'm not sure that a lot of people would necessarily say, oh no, BPD is not serious, but I think it's really easy for people to lose sight of, in the midst of all of this distress, there's some serious risk that I think sometimes it's like the frog in the boiling pot of water, that that often if somebody has BPD, they're experiencing pain so much of the time that people kind of lose sight of like the potential risk amidst that pain. And I think that that this isn't this is a disorder that has a pretty high mortality rate, that nearly 18% of all suicides, which is among the most, one of the leading preventable causes, potentially preventable causes of death in North America. And we're seeing that nearly a fifth of those deaths could be attributable to BPD. But I also think that there's a lot of other kind of major life impairing problems that are sometimes seen in the context of BPD for reasons that we don't always know. So we know that, again, pain disorders are really prevalent. Chronic pain, insomnia and sleep disturbance, sometimes obesity or some metabolic syndromes are disproportionately found in BPD. And so all of these things can really be impairing and get in the way of, people's ability to work and certainly to enjoy their life. And so these in part are maybe some of the driving factors in the lost productivity costs that we see associated with this diagnosis relative to people without the diagnosis. I want to go back because I didn't dwell so much on the diagnosis itself. And I did that in part because I assume that many of you are here because you know a lot about what the criteria, the checklist of what BPD is all about. One thing that I think is really important is that, I really in some ways hate the fact that it has personality in the name because it does make it kind of like, is it really about one's personality? But I think what that really is referring to is kind of the fact that this is something that's persistent across domains of life, but also that kind of varies in the population. And I do think it's important to know that there are a lot of folks who, even if you're not meeting full criteria, there's a lot of folks out there in the world who are meeting a handful of these clinical criteria of BPD. And in fact, even sub-threshold BPD is associated with impairments in functioning and living one's life as happily as possible. And so I think that when we start thinking about the sub-threshold folks, those folks with maybe 3 or 4 criteria out of the 9 criteria, all of a sudden we start seeing that the prevalence of humans that are affected by this diagnosis is now growing quite a bit. So this is just a summary of the first handful of myths that BPD isn't real, that it's a rare or only affects white women, and that it's not that serious. And so I wanted to just take a beat. This is about the halfway point and see if there's any questions related to this before I jump into the second half.
Just checking the chat now. I think that there's, okay. You mentioned you don't love that there's personality in the name. Is there, do you prefer emotion regulation disorder, or is there another name that's kind of being tossed around right now?
I mean, do I prefer it? I mean, I would prefer it probably, although arguably, technically you could meet criteria for BPD and not have meet for the mood lability symptom, although that's pretty rare. But something like that, I think I would prefer. But I don't see that happening anytime soon because it involves getting enough people to agree on something that probably won't.
Great. And then another question is, why is it viewed negatively? There's been associations with Amber Heard, and people having a negative connotation towards BPD.
Yeah, it does feel like it's like the last bastion of things that you can be discriminatory towards publicly, doesn't it? Sometimes that's how it feels to me. I know that's probably a feeling, not a fact. I think part of the stigma, which I think and I hope as I talk to more college students and younger folks, I do think that stigma related to mental health concerns is going down um, with subsequent generations, anecdotally. And I think a lot of the stigma, this is my worry, is perpetuated by healthcare providers. I've done some research recently that shows that healthcare providers still have a lot of stigma related to this diagnosis. And again, I kind of chalk this up to in psychology, we don't do a great job of advertising ourselves and teaching our colleagues. And frankly, not every graduate student who gets a PhD in psychology gets trained in understanding personality disorders. That's actually a pretty understudied and underrepresented element of a lot of training programs. And yet it's pretty common. And I think that probably part of this stigma is just related to the fact that therapists like knowing what to do. And they like being able to help people. And it's scary and upsetting when your clients are suffering. And BPD really is associated with a high degree of suffering, a high degree of self-harm, a high degree of all of the behaviors that we know are stressful, both to the patient, but also to their therapist. I think that this is actually one of the revolutionary aspects of a lot of the leading treatments for BPD is maybe not only what they do for clients, but how they support therapists in maintaining a non-judgmental stance and understanding kind of how to hold on to, their strategies, their supports, even when you have a client who's suffering and maybe makes you worry a little bit. So anyway, that's my theory, but I don't have data to support it. I just have anecdata, which is data of another kind. So I'll jump into the next kind of domain. So a couple of these myths are related to my worry thoughts about, or what I hear is that people are worried that they shouldn't diagnose BPD. I'm going to skip through this. Sorry, I had thought I got rid of that part. I think that there's a real challenge involved in whether to diagnose or not diagnose. And I think that this is something that providers need to think really carefully about. I think a lot of clinicians are reluctant to diagnose BPD because of very real fears of stigma. And I think that when a diagnosis is delivered in a way that is coupled with destigmatizing information, the more we can kind of normalize that these are problems that, yes, are problems and are associated with suffering, and that are pretty common and pretty treatable and people can routinely recover from. We can do a lot to kind of destigmatize conditions by allowing ourselves to talk about them. even if we don't like the name of the diagnosis. Another myth that I'll just touch on briefly, it kind of goes along with this, which is this idea that you can't diagnose BPD in youth. And it used to be thought that, like adolescents have this kind of normative storm and stress period, which is kind of true, but it turns out not uniformly. And that we shouldn't be diagnosing BPD until much later in early adulthood. And yet a lot of folks are actually recalling, oh, actually, my problem started pretty soon. And so we have this window where we can actually intervene a lot earlier. And it turns out that diagnoses in youth are pretty reliable. And so I encourage people to see specialists early if they're worried about BPD in youth, because the sooner you can have access to a treatment, the sooner you can relieve that suffering. And certainly there is some reason to think that we can detect it and treat it earlier than adulthood. And I'll just mention here, just because I think it's really interesting to see that actually BPD symptoms are often kind of peaking in that pre-adolescent period. And so we have this opportunity to kind of hasten the downward trend if we intervene early. This other myth is that BPD is a lifelong condition. This is another reason that I am nervous about having personality in that title, because the whole point of personality is this is something that follows you throughout your life. But that's certainly not the case with a BPD diagnosis. This is some data from cobbled together from a couple of studies, but mostly out of the long-term study out of McLean by Mary Zanarini, which shows rates of remission. Even after 2 years, you have nearly a third of folks remitting, and by 7 years, the vast majority of folks are no longer meeting criteria. It also looks like from this particular data set that the chances that you would then relapse, and once you've recovered, that you would relapse and then regain a diagnosis are actually pretty low. What can happen is you can have this remission, but kind of prolonged impairment, like not returning to full functioning, not being able to volunteer full-time or work full-time, that there might be some long-term impairment. But regardless, this to me looks like a success. And I think it's important to note that this isn't a study where not everybody was necessarily receiving treatment. So this wasn't a treatment study. So this shows kind of the natural recovery course. And I think we can speed that up with appropriate treatments. So here's our little summary. And I'll just hop to one of the scariest myths, I think, for families who are struggling with BPD is this idea that BPD is due to trauma or bad parenting. And I think maybe occasionally there might be a lot of trauma that is leading to BPD. But certainly not exclusively, and this is not a one-size-fits-all recipe, right? We know that actually there's a lot of folks with BPD who don't have super high rates of trauma and abuse in their childhoods. And there's also people who might have traumatic experiences and end up with a different diagnosis or maybe even no diagnosis. And so that this really is often a transactional dynamic model where there's likely a good chunk of heritable elements that set the stage for somebody to be really, really at risk. and then a goodness of fit with the environment, where sometimes you have some people who have higher needs from the environment that they are not able to meet. I worry about this myth, not because, mostly because I want to make sure that parents are not being scared away from taking their kids into getting treatment, which is if you're worried that it's going to be because of you, it can be really daunting. And I will say, I know I'm noticing the time. From my own research, a lot of my research has looked at how different parenting styles interact with child vulnerability, like emotional reactivity. And long story short, different kids need different parenting strategies, and there is no one size all. This is what good parenting looks like and what bad parenting looks like. And the things that will increase risk for one person may reduce it for another. And then this original myth that I think I started off with, which is this idea that BPD is untreatable. And I think that we now have ample data to show that there are many, many evidence-based treatments for BPD. And in fact, most of these studies of these treatments, when they compare any of these lovely treatments to an expert comparison condition, by and large, any expert condition, any specialized expert treatment seems to work pretty darn well. So I think there used to be this idea that this was the diagnosis that needed like incredible specialty care. And, as a DBT therapist, I love DBT. I think it helps a lot of people. And I think that that there are a lot of treatments out there that could be helpful for BPD. And so I'm noticing the time. I'm just going to jump to, I guess the other piece that I just want to mention is that it also used to be this idea that only really, really long-term treatments would be helpful. And increasing research is showing that that's not the case, that even 6 months of treatment can be really helpful. And there's even evidence to show that 6 months might be in some cases better than 12 months. Maybe because it gets people back to their lives. So here's my take-home points, that I think BPD is a disorder that exists, that affects people across racial and ethnic categories, men, women, at much higher rates than a lot of people realize. And that we can diagnose this condition reliably, even in youth, connecting them with care. That a lot of our kind of historical ideas and myths about how BPD develops laid blame at one side of the equation or the other. And increasingly, we can see that this is kind of a dynamic risk profile, and that there are certainly a number of valid treatments at this point in time, even brief ones. So with that, I will say thank you to BPD Society BC for inviting me. I think I only had about 30 minutes, so I think I have just 2 more minutes for any last questions.
Wonderful. Thank you so much. Yeah, there's 3 questions in the chat. So the first one is more of a comment to expand on. So I think the myth that BPD only affects white women is born from the medical landscape North Americans have to contend with, where mental health care is hard to access for anyone, and that access gets more difficult as we go down in privilege. So maybe speaking a bit to privilege and BPD treatment.
Yeah, no, I think that that's right. I mean, I think that, a lot of the programs you wouldn't have access to, especially in the US, unless you were in a position of privilege. And so we're disproportionately seeing white people accessing care. And so it gave this idea that this is what this disorder looks like, and it's absolutely not the case. Oh, I can't hear you.
Is the high rate of BPD among college students due just to the age range or to other factors?
I can't tell you the answer to that, except to say that I now work at a large university, and I will say that college students are really stressed out. We pluck them out of their nests and put them in a situation that's kind of competitive, often has a lot of substances around, and take away their support systems. And so I think a big part of it is probably the developmental age range, that there's that kind of natural decline that happens in symptoms. And I think that that's probably amplified by the stressors that college students are encountering while simultaneously maybe losing some of their existing support networks.
Great. And lastly, I'm wondering how clinicians run into billing problems when it comes to diagnosing BPD.
That's a good question. I have never run into a billing issue. I will say in the US, there is some concern if you're in a veteran treatment context that different veterans can have different kinds of levels of coverage based on whether they sustained harm in combat. And so the idea that BPD is a personality disorder could indicate some sort of pre-existing problem, when in fact I would argue it's often not the case, and it can very much be amplified by stress. So but I do think that that's often where billing challenges lie, are in American or in the US systems.
Wonderful. Yeah. Thanks again so much, Katie. It was an honor to have you here today.
Thank you very much.
Yeah. Take care.